All right, so welcome to Borderline and Strong. So, really, what we'll be doing today is myth busting borderline personality disorder. I think it's come to the forefront a lot more recently, and more people are talking about it in relation to trauma, to PTSD, to personality disorders, anything. So, we'll just get started on that. Okay. All right. So what we're really going to be going into is the origins of BPD. Why I go into this is because it's going to help you understand why the name, why the stigma, where did this come from. Going to run through the basic criteria for you because we may have an idea of what it means, but once we really look at it all on one page, it can be a little easier to understand what we're actually dealing with here. I'm going to be debunking a lot of myths about this because this is one of the most stigmatized diagnoses there is. And there's lots of myths about them that are very ableist, misogynistic. So we're going to debunk those. We're going to look at the heart of BPD, what it means, where does it really derive, how does someone get that diagnosis? Types of treatment out there. I'll go over that briefly, especially the more discussed ones, and I'll go deeper into the other ones that are finding to be really helpful for this. And then really the whole summary of what we'll be working on is encouraging empathy for this. Whether you have it, you think you know someone who has it, you have had a potentially bad experience with this personality disorder, whatever it might be, whatever you came here for, I'm going to try to explain it from all sides. So, but I think the first thing is at the end of the day, I am a licensed mental health counselor. I specialize in trauma and PTSD, borderline personality, as well as other personality disorders, dissociative identity disorder, human trafficking, cults, survivors of war, pretty much anything in the trauma field. So with that, I am also someone that is in remission from BPD. So I hope that I can bring a unique perspective of talking about it in some of those personal details, but mostly I'm going to keep it research and reality based so I can give you guys the best knowledge that I can. All right. So interesting origins here of borderline. And again, let me know if you can't if you can't see my screen. It's not, it's saying that I'm screen sharing, but I keep seeing my own video. So just let me know. All right. So the term borderline, a lot of people have thought that it comes from, going between the black and white thinking that can happen in that, which we'll get to later. But it actually comes from the idea that people with borderline personality disorder were suffering from borderline schizophrenia. That is actually the original term. So if we think about people back in the day looking at someone, and of course, as we should never stigmatize psychotic disorders, but still, putting that label on someone that's dealing with emotional regulation issues, that's pretty extreme and shows a very low lack of understanding. So the old terminology of, neurotic, and that went alongside, well, you're treatment resistant and you're also impossible to treat. Honestly, the stigma of treatment impossibility, I have been hearing since all my time in the field up until maybe 2 years ago. I've started hearing this idea less. So this stigma has really dug its heels in. This idea of, well, once you get borderline, it's stamped on your head. There's no treatment. Forget it. That's your life. We'll get to that in the myths and the treatment, but that is incorrect, 100%. People with borderline personality disorder were also looked upon as like primitive and animalistic in ways because of their unpredictability, which really this goes back to a lack of understanding of emotional dysregulation and the actual strong empathy and intuition of people with borderline personality disorder. So a lot of people with BPD, before the diagnosis was known, were put in institutions for a long time. So alongside folks with psychotic disorders. And again, this really has a lot to do with the age of psychoanalysis, which, as much as I can appreciate certain aspects of it, psychoanalysis boils things down almost beyond what it really should be. So there's always an easy answer for everything. This was very male-dominated, white-dominated field. A lot of class issues, lack of understanding of really the mental health experience of anyone else but white men. So that kind of goes hand in hand with the lack of trauma-informed care. This idea of people are just neurotic or hysterical. You know, the origins of the word hysterical and hysteria and how that was treated. So eventually, like with anything in mental health, we eventually got there with an iteration of borderline in 1980, with it finally being added to what's called the Mental Health Bible, the Diagnostic and Statistical Manual of Mental Disorders, which now we're in the DSM-5. So every iteration of that gets a little bit more, I would say, justice-oriented and truthful. Okay, so now we're just going to sit here and look at the diagnostic criteria real quick and try to actually sit here. I really want to invite you to kind of think about what these things might feel like if you don't experience them yourself. So we start with chronic feelings of emptiness. If we've ever felt that, we know just how devastating it is to not just feel so overwhelmed or underwhelmed, but that there's a sense of nothingness. That can often translate to feeling like we're nothing, we have nothing. Emotional instability. This is the fast vacillations of up and down. So a lot of times this gets misdiagnosed for bipolar and vice versa, when really the difference in bipolar is that those have to do with typically more chemical mixed with environmental situations. So unless someone has bipolar that's rapid cycling, typically these swings of feeling low or feeling high in a hypomania or a mania are going to be sustained for a week, 2 weeks, depending on what type of experience they're in. Whereas with borderline personality, this can happen within the hour, within the minute, where it's snap. Something is said, a feeling is felt, kind of a vibe is picked up on, a micro expression that someone made, and now we're off to the races. Frantic efforts to avoid real or imagined abandonment. Sometimes this little sentence can sound a little problematic and judgy. However, I think at the end of the day, if we pick it apart, it's pretty accurate. The frantic efforts are a lot of the sometimes guilting that can happen, not that we want to guilt people, but just the things that are said in a moment of great fear. We have to realize that trying to avoid abandonment, this person's in great fear that they're going to lose their stability, their person, their people, their family, whatever's been giving them stability. Because really this is a crisis of connection. So the frantic efforts, unfortunately, tend to push people away who don't understand. And sometimes we all know we can have problematic behaviors at times, but the intention is truly not there to be hurtful. Identity disturbance. A lot of times I say this one's best with examples. This can be, for instance, say, if you've ever met someone who kind of takes on your verbiage or the way that you speak or almost like a dialect, but they can change that around different people, easily influenced by media, as in like maybe they see something, a character they want to mimic or feel like them. Really what this person is trying to do is, it's not that they don't have a personality, which is often said, like this person has no personality or they're copying. It's not about that. What it's really about is someone trying to find their footing in a world that feels very confusing and unsafe. So there's levels of comfort in being able to kind of try on different ways of being human. So it's kind of like what we would do in adolescence. We typically aren't solid in who we are. We kind of try on different things. Impulsive behavior in at least two areas that are potentially self-damaging. That's pretty straightforward. We can see a lot of compulsive behavior, compulsive and impulsive. Spending, sex, substances, reckless driving, binge eating. And what I'm saying about these things is not so much impulsive, but focusing on the self-damaging part. So it's not so much someone's sex drive or level of sex that they're having or spending or eating. It's that it's coming to a level where it might be becoming unsafe. Like, for instance, with sex, like maybe someone's just kind of like, I'm not going to use protection. I don't care. I haven't gotten, my talent testing, blah, oh well, like stuff like that. Reckless driving, pretty straightforward. Binge eating, points where we're getting GI discomfort, we're getting headaches, we're putting on weight way faster than our body can take, substances, and spending, of course, beyond our means, and maybe putting ourselves at risk for losing the larger things in life. Inappropriate, intense anger or difficulty controlling it. Now, what's really meant by inappropriate here is that typically the situation that triggered the anger is fairly innocuous, but the response is very deeply felt. And most of what's happening here is not so much just anger pissed off, but there's a deep level of hurt. The primary emotion of anger, if you just kind of imagine it like a little ball, inside is hurt. That's what's under the iceberg. So that's what you're seeing. And that typically links up with the frantic efforts to avoid abandonment. Like, you can't leave me, fine. We either dismiss or we really try to draw people in with lots of romantic moves, crying. And again, it's not like this is calculated. Someone isn't sitting there thinking, well, I'll do this to do this. It's just happening in these large waves. Pattern of unstable and intense interpersonal relationships. By the way, that's my cat playing and screwing around, just so you know. This is called splitting. So idealization and devaluation. So just imagine 1 minute someone could be your world, the person that you do not at any cost want to abandon you, hurt you. This is your person. They do something, they say something, and now it's like, I will make them pay for everything that they're making me feel right now. And actually, I don't need them. They're garbage, and we can fly right to devaluation in a matter of minutes, hours. It could be even just a little comment someone says, and there's something about the content of that causes a lot of deep pain. So we split on the person, and that's a way to keep ourselves safe in a way. Coming from, say, childhood, we have to dismiss the person, or sometimes that almost God complex will happen where it's like, shh. But really at the end of the day, we're really hurt by the fact that this person said or did something, but we don't know how to communicate that in a way that's fairly even keel. and recurrent suicidal gestures or self-harm. Chronic suicidality and chronic suicidal thoughts are very common with BPD, as well as there's a high hospitalization rate and attempt rate. Thankfully, this is starting to go down with more treatment and understanding, and the understanding that there is actually recovery from this. And paranoia or dissociation. Because a lot of BPD can be linked with trauma, we're going to see dissociative elements. So we're going to see, losing time, leaving mentally a situation, checking out, because it's safe. They feel safer to be staring at the wall and in the wall, basically, or on the ceiling, or wherever our mind brings us, instead of in a world where at any moment we feel like our stability could be taken away. So I'm just gonna, okay, good. I was just making sure all of our participants could still get in. Just making sure there was no one in a waiting room. Okay, now here's something that I never really hear folks talk about that I really was excited to share with you guys today. This is not in the DSM. You won't see too much about this, but it's something becoming more largely discussed. And I think for those of us that may think we have this, do have this, know someone with it, this might help gain some understanding. And it's something you could look more into. So there have been identified 4 types within borderline. I don't know how much I agree with some of the names, but this is where we're at right now. So I'm just going to present it to you as it is. So there's the discouraged type. This you'll commonly see more in the male population with borderline. You can also see this in, I would say more women, some non-binary folks that have grown up with maybe sensory issues or autism spectrum. This is considered, it's also called the quiet borderline. So most of the stuff that would usually be happening externally with people with BPD, which we'll talk about as we go around, is going inwards. So there's lots of almost like a fearful child, just kind of looking around saying, who can I trust? But I need to trust, I need my people, I'll do anything for them. But inside, the tumultuous feelings, the pain is so severe. There's a very strong dependence on others. This can also look a little like, dependent personality disorder, other things like that. So it can be hard to differentiate. There's a very strong sense of loyalty. That's the thing with this, is that there's less of the behavior of like the emotions coming out in a way where other people might react negatively. Everything's going on internally for this person. So they tend to be more passive, people-pleasing. They're not going to say anything that could upset the person. It's almost like they're just quietly like, I can't speak or move. As long as this person accepts me right now, I'm not going to do anything to muddy the waters. So feeling very unsafe to be themselves. And they are very self-reflective and serious. The impulsive type has more of a flare in behavior, and what I mean by that is that it's a lot more visible to the outside world. It's similar to histrionic personality disorder, which is a personality disorder that a lot of people just say is dramatic. There's lots of flirtatiousness and kind of eyes on me, will somehow end up having situations kind of come back to them. But the difference between histrionic and borderline impulsive type is that the histrionic person actually has fairly healthy self-esteem, whereas the impulsive type of borderline does not. And really, they're kind of doing fake it till you make it, shifting into that God complex moment that we can sometimes get in when we have been rejected or abandoned and we want to feel some sense of power and control. So again, flirtatious, charming, quote, dramatic, easily bored. Petulant. Again, this is really the word that kind of rubs me the wrong way because it makes me think of like a petulant child, which is not what we are, but it's closely related to the idea of borderline that I think most of us have, so fairly classic to the diagnostic criteria we looked at. A lot of outburst, feeling unloved or less than, a lot of challenging others about their care. So lots of not so much like, do you like me? Do you love me? But like really strongly asking someone that, like, do you even care about me? What even are we? What's going on? You don't seem to like me anymore. What you just said. You seem to have a problem with me. Like kind of more, I would say aggressive in a sense, although that's not exactly the word I'm looking for, but is ready to kind of challenge people. Guilting can come along with this, although not calculated. Just happening to say things that other people may feel guilted by. And a very strong need for control. This person with the petulant type would be very much in pain. Then there's the self-destructive type. There's extreme lows in self-worth and value, linking back up to the chronic feelings of emptiness. This type has a lot to do with self-hatred, self-sabotage, and how I would kind of tie that up is living suicidally. And that kind of goes back to the recklessness. You're living life in a way where you just really don't care. Like you don't have the energy to care about your safety anymore. Your safety, your interest, what you're passionate about, what's best for you. It's just kind of to the wind. A lot of hospitalizations with this type and major suicidal gestures and follow through that can result in longer hospitalizations. I just wanted to show you guys this just to kind of give you an idea of those of us without borderline would kind of vacillate up and down these spirals fairly slowly, whereas those with borderline can go from the top, like almost like a high, not exactly like a mania, but somewhat close, a high of either a God complex or like finally things are somewhat okay. But then because inside there's this sense of, I'm not allowed to have this though. So if you're not going to take it from me, this is really a struggle when we find people that are actually worthy of trust and are safe. We don't understand. It does not fit the schema or the template of maybe what we've grown up with, especially if you look into insecure attachment styles. That'll tell you a lot. Parents that since the beginning you could not rely on them to meet your need. You didn't know if you'd get fed, changed, interacted with, loved, and when you needed it. And that's what we're supposed to do with children, is not make them wait it out. They need to know that they're secure with us. So when we don't get that, we get abuse at sexual, physical, emotional abuse at strong points in our life when we're trying to develop. So middle school, high school, really anytime during childhood, you hit those major points. Now we have a potential to develop BPD. So there are lots of environmental factors, childhood factors, and then also generational factors of, is this trauma passing down during generations? So now it was a parent who was raised by parents or a parent who couldn't provide any love or care or support, now raised by someone else who now doesn't know how to do that, and now they're raising me. So, and then we have a parent who doesn't know how to sit with a child while they cry, or when they've been bullied, or when they've been hurt, and we have now someone is sitting here going up and down these spirals because the self-soothing was never taught. Okay, now we're going to jump into some myths. So I'm just kind of trying to keep track of time. I could tend to be long-winded, really, because I care about you guys and I want you to be informed about what you came here to be informed about. Okay, there's a very upsetting myth that people with borderline are insane, abusive, or violent. Now, because I am also not here to invalidate people that may have been hurt by someone with borderline. I'm not saying that things that are done during outbursts or painful moments are not abusive behaviors, but the person themselves are not an abuser or abusive. I'll put a little asterisk on that because I can't speak for every situation. But remember, I am trying to bring empathy to this personality disorder and try to bring some more understanding. So I'm definitely not going to say that all of us that have this are, angels and have never done anything wrong. Our behavior can very much have repercussions on other people and hurt them and confuse them and shock them. I've been there, I know. But this idea that we have some calculated want to really hurt people because we want to hurt people is not what's happening. It's not like, even when it's these vengeful thoughts or revenge ideas, that's in that perceived abandonment. So it's not someone sitting there just saying, yeah, I just want to hurt this person. I want to get them just because I can or I should. It's mostly someone trying to defend themselves from what they think is inevitably going to be the end of their world, losing their person, losing their support. And people with borderline are more so, quote, violent towards themselves. Just like really mental health, statistically, those of us with any mental health concerns are much more likely to be victims of violence due to lack of understanding than perpetrators. So, of course, there are outliers, but overall, most of the harm is done to self. So the fact really here is that people like us have difficulty regulating emotions. It feels like we just have to go with how our body feels and what our brain is saying, and we're off to the races. Another similar thing is that people with borderline are sociopaths or psychopathic. And I just want to put in stigmatization of cluster B disorders, which is antisocial personality, histrionic, borderline, and I'm probably forgetting one because I'm on the spot, but if you look at cluster B, they tend to be the ones that more people know about. It's harmful. These are, again, mental conditions. That doesn't mean that people with those cannot hurt people. Again, I really want to reiterate that. This is not, where I'm trying to idealize those with borderline and put down those that may have been affected. But people with borderline are not sociopaths or psychopathic, and those are actually not even clinical or real terms anymore. But this is kind of the words that people will say. Because to really meet the criteria of what people are mentioning there is calculation, premeditation. That's not what people with borderline are doing. It's typically snap decisions that end up being unsafe. I've heard this, I should have put quotes around it, but only women have BPD because they're neurotic. No. It's classically diagnosed in women and femme folks. But that is not the whole story. There is a plethora of men, non-binary folks, all different other genders that have this diagnosis. I think the reason that people jump so heavily to borderline for mostly women is this old misogynistic idea of like you're neurotic, you're hysterical, you're deep in your emotions. Oh, maybe you had some trauma along the way. Borderline. Which may be the case, but there's not a lot of empathy in coming to that conclusion. I've seen a lot of people get misdiagnosed, or really they were actually dealing with bipolar disorder or a different personality disorder or just straight up PTSD, complex PTSD. It wasn't borderline, but people weren't listening long enough to hear that it wasn't. So I just want to reiterate, borderline happens to plenty of men. There are representations out there. Can't remember his name right now, but there is a famous basketball player, and I think his name is Brandon something. He speaks out about it a lot, so I definitely encourage you to seek out some representation. This is one I get from a lot of parents. Borderline is just teenagers being teenagers. This is just your normal behavior. Now, as nice as it is to hear a parent not overdoing it and jumping to, oh my God, my child has this, let's do this, let's do that. We also don't want to misunderstand. Borderline is very complex. It does typically begin in adolescence. So that and teenage life together, there can be a lot of similarities, and yet it's dissociated from the teenage experience. The teenage experience is not typically chronic suicidality and gestures, extreme recklessness, abandonment problems. That points to something different. So I really encourage people to look a little bit deeper when they think, it's just this. Because we might stop someone from getting help earlier when it really could be helpful. If you catch this early, then you have a lifetime ahead to kind of get a jump start on treatment. But unfortunately, the truth is, if this was created in the household, for instance, generational trauma, lack of secure attachment with parent abandonment in the home, that's probably not the parent that's going to encourage us to seek help. Okay, so I felt like, I don't want to speak all day long about my experience of borderline. Yes, Brandon Marshall. Thank you so much, Sharon. You nailed it. Brandon Marshall is the male athlete who has been diagnosed with borderline. I'd really encourage you to look into him. He has a great Twitter. He gives a lot of support. So thank you, Sharon. So if I have time, I might tell you a little bit about my story, but really I wanted to just show you a couple of quotes of people that have borderline, including our borderline queen on the left, Miss Marcia Linehan, Dr. Linehan. She was a suicidal teenager with borderline, lots of extreme behavior, hospitalizations. Guess what? She worked in recovery. Of course, we're all still recovering. She created dialectical behavior therapy, which is the top treatment for borderline. And she's here helping us today. And I think she gives a great understanding here. It is truly like having no emotional skin. Everything that touches us, especially those micro expressions, when you see something cross someone's face and you just can't buy that they're okay. They're like, are you okay? Is there something wrong between us? We're fine. And we're like, no. And then we almost create, again, the abandonment narrative. Well, if you're not going to leave me, I'm sure going to make you, because I need this to make sense. And again, we don't want that. That's not the actual deep soul want of our true core self. But our old behavior patterns say, this doesn't make any bit of sense. I need it to make sense. So if this person's going to dig their heels in and stick with me, this isn't going to work. Especially when we're new to treatment, never have had the option for treatment. We don't know what options are out there to get better. So like this middle one, fluctuate between fearing abandonment and encouraging it. And that, I know Jan meant by those non-calculated behaviors. Like we just do it. We think that's our gut saying, just get that person, just irritate them, tick them off, say the wrong thing a couple times, say something that's going to crush them. Again, this is not, we're sitting there like this. It's just happening. And that is why. And really, it's a scream for love. That's what I really want y'all to know, is that this is a scream for love and support and security. Okay, so I know I probably have a couple minutes. So I'll run through this, but treatment of BPD, first things first, treatment is possible, achievable, and within your grasp. It may not always be perfectly accessible in your communities, but I think with telehealth and some folks doing more sliding scale, more people getting educated, we're going to have more practitioners available. Therapy types, dialectical behavior therapy, that is the top treatment, which really has a lot to do with mindfulness, emotion regulation, distress tolerance, and building secure relationships. If you want to start anywhere in your treatment or in your knowledge, please check out the DBT workbook. I know I have a PDF somewhere. I could probably get to those that are interested, so I can leave the chat open after and just answer questions. Because I know I'm the host now, so I think Leia may have gone to sleep. So so I don't want to bug her, but yes, I can keep the chat open. Maybe try to find that for you guys. That's a great way to start your journey before finding a therapist that specializes, because that can be hard, because the training is a lot of cash. I will say I don't have this training yet, and it's more intensive. It does better in intensive outpatient as opposed to your kind of weekly, bi-weekly therapist appointments. And more often you can find it in private practice, which again brings up the price tag. Mindfulness-based stress reduction, EMDR. I will always sing the praises of EMDR, and I'd be happy to answer more questions about it if you'd like, but I don't want to hyper-focus on it just because I love it. Somatic experiencing has a lot to do with mindfulness and respecting what the body's feeling while also learning how to tolerate it. And, oh, okay, sorry guys, he just wanted me to go back to the screen. Excuse me. Thanks. All right, so somatic experiencing has a lot to do with getting into the more body-based treatments, which are excellent for trauma-oriented conditions. And internal family systems. This can help us realize the different versions we have inside. You know, our child self, the old teenager, the old petty person inside, the old, the lover that we have inside of us all, the artist, all the different versions of us, and help us kind of integrate and realize that no part of us is bad, and they all typically have motives that are for our best interest, but sometimes do things based on old stuff that isn't happening anymore, which I find is really what most of our conditions have to do with, is we're just using old coping skills that no longer work, but we're afraid to stop using them because we're unsure. So we keep using them because we don't know that things are different yet, or we don't trust that they're different. Quick thing on medications, I really like to get best info out there. These are just for symptoms. There's no medication for borderline. These are for symptoms of the depressive lows and emptiness, low appetite, lack of sleep, mood stabilization, anxiolytics, which are the anti-anxiety medications. So there's been a lot of research done on Depakote. Depakote actually has very high statistical numbers for being successful as a mood stabilizer for borderline, as opposed to any other one. Amitriptyline is a tricyclic antidepressant, so a little bit of a newer one that has also been found as very helpful specifically for borderline. So I just want to put that out there in case you'd like to research more. Because sometimes I just think people say, you've got mood swings, all right, you're bipolar, here's this, and now we're on a medication that may actually be creating more symptoms. Because when we don't actually have something that's typically organically based, as in like generational, like depression or bipolar, now you're creating the symptoms of that, which is just going to complicate things more. Quick note, no judgment, no hate here. But a little note on benzodiazepines, like the Xanax, Klonopin, Ativan families. over time, these actually very much don't help recovery from borderline because it is basically numbing out the emotions, which of course we all want in the moment. Absolutely. The point of getting prescribed this and taking this is we don't want to feel such a strong intensity. But unfortunately, nothing really works without therapeutic treatment, self-treatment, actively working on borderline. Over time, the benzodiazepines can really mess with memory processing, and you don't want to end up with unprocessed memories and then stuff years down the road popping up even stronger than it felt in the moment. So just a little note there. There's no judgment here if that is you. Okay, I know this image is not very clear, but I wanted to make it big. So, some recovery rates. These are a lot higher than we would have thought, right? Definitely a lot higher than not treatable. So just hold on to that if you think this is going to be your life. I used to think it was going to be my life. I was chronically suicidal, self-injury, very severely, drug addict. Oh my God, I just slept like an hour a night. I was driving. I used to drag race, drift, crazy all over the place. And I only say crazy for me. I don't label other people with that. I'm just saying out of control. Angry, like an animal trapped in a corner. No trust. Over time, I learned with lots of treatment and assistance and lots of reading, and of course my own journey into becoming a therapist makes you look at yourself under that magnifying glass quite a lot. I kind of weathered the storm. It's almost like you're like, I don't want to trust, I don't want to do this, I don't want to feel this, but frick, I have to. Like, I just have to. And it took years, so I'm not going to say that this is some snap, easy journey. I still have, I would call them like micro outbursts. I still definitely have the feeling that comes up that I have always felt when I felt like something was going to happen. It still comes up. I just know how to talk back to it. I know how to manage it, cope, and make sure that it doesn't come out in a way that's hurtful to myself or others. So I just want to let you know if you've got feelings or you've got intrusive thoughts or you're saying nasty stuff about other people or you're feeling vengeful, it's normal. If we've gone through a lot of trauma, we've got such compacted rage and hurt that it's going to look like that sometimes. So I will leave you with this before questions and kind of wrap it up. Just to read that. So it occurs in the context of relationships. Unlike other psychiatric diagnoses, if you put someone with schizophrenia on an island all by themselves, their mental illness would still be evident. If you put someone with BPD on an island, you wouldn't necessarily see the symptoms. Whatever happens, happens in the context of interacting with someone else. Okay, cool. Just realized something that Sharon said. You can probably see my screen. I think I shared everything. So. All right, so once we've kind of sat with this, I am just going to kind of open it up for questions. Don't feel pressured to ask, but I really love questions. They kind of keep me on my toes. If you just want to know more about people that have BPD, anything else, let me know. I will stop my sharing. If there's something you need or want me to go back and look at, just let me know. So other than that, I think I sent my email just directly to Sharon, but I will send it to all folks. Please, as long as it's not clinical, too deep clinical information about yourself, as I, oh, okay, got a good question from Eva. Let me get to that. So, I'm sorry, I forgot what I was saying. Oh, I also think I have a Q&A yes, oh my goodness. Okay. Oh, good. You just sent that in. I don't know if you'd like me to say your name, but someone did ask. So I will answer this question live, and then I'll get to you, Eva. I just didn't want to forget. Is it common to have borderline and bipolar together? Common, I think, as in a lot of psychiatrists specifically will diagnose this. But generally, when someone's really authentically looked at in a way that is very trauma informed, I would say it's a little less common, but very much possible. Because borderline personality disorder, that has to do with how we interact completely with the world and ourselves. And then bipolar is more of that organic, bipolar 1 or 2 is more of that organic condition that's dealing with brain chemistry. So absolutely, you have generational bipolar maybe in the family. Then we have some environmental abandonment issues. Absolutely, it is possible to have both together. Just need really thorough assessment by someone who's trauma informed, I would say. Okay, I also have someone who is a DBT clinician. Are you familiar with transference focused psychotherapy, and do I have an opinion on its usefulness? I would say I'm fairly familiar with it, and I find it pretty useful. I know it's coming towards more of the psychoanalytic stuff, but I think we can do a lot of healing in the room with somebody. So what I mean by that is I think therapists, if they're in the right space and they're focused on what's happening in the room, using the immediacy of what you're seeing, I think we can do a lot of good work with our clients. So I know that was kind of a short answer, but what I really mean is I appreciate when a therapist can sit with a client with borderline and be present to them and respond to them. And if something happens in the room or on the phone, I've had that happen a lot, address it right then and there. Allow a moment for that person to build emotional strength and for you to be authentic and real and understanding instead of the old attack defense. And I'm going to go back up to Eva because I apologize for not grabbing that. Any tips on how to learn to love yourself with borderline and not feel like you're a bad person? Well, my major response to that as someone who did that and actually truly feel like I love and care about myself and have strong self-esteem. I'm going to say this, it might be kind of controversial that people that have tried it or had it shoved on them. Self-compassion, mindfulness. If you look into Kristen Neff's work and do some of her meditations, again, I'm not saying you'll do the meditation, now we feel cool and all good. But the language of acceptance. Trying to strip away ourselves from the positive affirmation stuff. Toxic positivity really fails in borderline treatment. This idea of, well, now my cat's hungry, so you'll just have to listen to the symphony. Going from, I feel like I'm a piece of trash, or I'm less than, or I'm a bad person, to, I'm the best person in the world. We kind of do that in our God complex moments, and that hasn't done much for us. But when we can come to, I'm okay as I am, or I'm no better or worse than anyone else, and start trying to believe that, by practicing a lot of mindfulness, being able to sit in our body and ride the waves of strong discomfort and realize it's not going to kill us. When we were a child, we thought it was going to kill us because no one told us it couldn't. So when we're a child and no one comforts our tears or our pain, we're not supposed to know how to do that yet until we're taught. So if someone doesn't do it, we think we're actually going to die because we're dealing with more primitive brain. Children don't have the whole frontal lobe developed, so they can't sit here and think, oh yeah, well, my mom's had a rough day or she's had a rough life and she can't be here for me. It's, I'm being rejected. Rejection means death. Now, a child's not thinking that, but they are feeling it, and that is what leads to the brain scans that you'll see, which show children with abandonment issues and their issues. Okay, I'm going to answer the one in the chat. I have some Q&As. Sister and mom were diagnosed with borderline. Daughter has all the symptoms. Doctors are hesitant to diagnose. She's 12. Diagnosed with anxiety, ADHD, and OCD. And these occur together with borderline. Technically, yes. Especially ADHD. So ADHD, however, this is where it gets really complex. Things within ADHD, OCD, and anxiety can mimic a lot of stuff in PTSD and borderline, as well as vice versa. So again, that trauma-informed lens of where did this behavior derive from? Are we ADHD? Are we inattentive because we're dissociating? Because we don't feel like anyone wants us in the room? Because we're anxious? Because we feel like we have low self-esteem? Or because truly I can't focus because I have ADHD? It opens up that door. Because if a teacher just says, hey, you got ADHD, you're jumping off the walls, okay. Some children are also on the spectrum. Some children also have PTSD. Yeah. And then OCD, it really depends on the thought content and what they're doing. A lot of people with PTSD and trauma-related disorders can certainly have lots of OCD. So we have to look at what's the heart. I often find in all my work that the heart is trauma and the heart is some sort of PTSD. So yes, absolutely, your child can have those, but I would encourage someone to look further, and I know that they're hesitant to diagnose because it's still a stigmatizing diagnosis. But I encourage you to, a really good website for a lot of rare disorders is themighty.com. I think it breaks it down in a really understandable, empathetic way. Okay, let me get to my Q&A. I'll get back to Eva. Can I ask, how did EMDR help you? Yes, of course. Yes, and someone asked me about the meditation. I will definitely take care of it. Well, I really could go on a rant about EMDR. So I would say it helped me integrate. So really, without going into a whole big thing, the heart of EMDR is taking the traumatic memories and pulling the severe emotional content from them. So you can look at it, like right now, I'm looking at a very traumatic memory of mine in my head. And my innate reaction is, okay, that was a part of my story. I don't like that it happened, but there it is. Whereas in the past, I would be crying, dissociating for hours, not even know where I am, who I'm talking to, irritability, whatever. So what EMDR is about learning the truth and actually integrating it inside by evidence-based treatment, by actually reprocessing the memories to where they need to be. Because memories are not supposed to be in our reptilian brain and the amygdala, they're supposed to be in the hippocampus. So bringing a sense of neutrality. So it's not so much that memories can't upset us anymore, but that they don't take our time and life away anymore when we think of them, if that makes sense. So I am an EMDR, I'm EMDR certified. I'm also a consultant in training. I really encourage you to look into it, but if you don't feel you're ready, if you're someone who's like, no, I don't want to talk about that, I don't want to think about that, there's other work to do. And your time will come, and I promise you'll know. And if you try it and you're like, not yet, oh, that's too much, don't do it. Try again later. I promise you'll get there. And yes, I can put the name of the person with the meditations for self-compassion. She is an angel. She's got lots of free activities. The self-compassion break. Even just learning about what self-compassion is very helpful. Okay, and then back to Eva. When starting to date, at which point would you tell the other person that you have borderline personality? I'm all for authenticity, first of all, I'll say that. I'm not someone that likes to over-label myself. Actually, recently my therapist was like, dude, you tend to just put labels all over your profiles. Like, are we proud? Are we trying to warn somebody? What are we doing? And that kind of brought to mind, am I putting these out as like a beware, you might not like me if you know that I'm, autistic or have PTSD or work with, whatever. I would say after I get a sense that the person has a sense of empathy, and I know that's not a specific date, we should hopefully know that before the first month. I pray that we know that the person we're speaking to has empathy for people other than those in their own population. And then I always recommend giving information to immediately combat the stigma. So lots of great articles. There's one, if you look up like the truth about borderline, there's a place that specializes in it and writes this very nice article about like kind of what we're talking about today. So not just, not that it's our job to educate, but kind of directing people to not just type in borderline and read horror stories and get afraid of us, because there's a lot of BS out there. So I don't see any more Q&A or chat, so I will hang around for a minute or two. I'll get my email out there, and if there's anything I mentioned that you want me to link you to, that's my personal email. I would say if you'd like to email me, because maybe after I end this you forget and you're like, I want that meditation or that script or something. Yeah, just let me know. I would encourage you not to email, since that is just my simple private email. I don't use that for work. It's not encrypted or anything, so I wouldn't send your personal information on it, as in like mental health status or anything, that you wouldn't feel comfortable sharing. But I definitely encourage you to reach out, even if it's a week or 2 weeks after this, because stuff comes up. And I will send you guys one more thing. Sorry, you're hearing me type. I promise I'm not trying to do shameless self-promotion here, but I do create a lot of meditations that were specifically requested by my own clientele to create, because they felt like there wasn't enough out there. And so I have some flashback protocol, intrusive memory work. I have some mindfulness-based stress reduction, because I am an instructor in that. So finding that for free. So all these, this link to my meditations, it's a free app. Sometimes it'll ask you want to subscribe to something. You don't have to access everything. It's just like special stuff. Kind of like Spotify or something. If you want special stuff, you pay. But other than that, you'll have access to everything. All my meditations are free. And I encourage you to just use that app to start your journey looking into mindfulness and self-compassion. And just little thing before I go is that if you're going to go into the mindfulness journey, really something I like everyone to know is that sitting and being able, it's not about doing this perfectly for hours on end. First of all, we shouldn't even be doing that for hours. Try 5 minutes, try 2 minutes. The work is done when you redirect yourself. So if you were able to sit there and quote focus on whatever the prompt is in the meditation, that's nice. No real work has been done except maybe some relaxation. But when we're working on changing our neurons that fire together, wire together, when we're learning something new that's really freaking hard, the work is done when we say, oops, I got distracted. All right, let me not think about food right now. Okay. Nicely, we don't say, I can't believe you can't focus, blah, I suck at this. No. Even if you get that thought, I suck at this. Okay, that's a distraction. I'm back. Okay, my cat literally just stabbed himself in the face with the corner of my computer. Anyways, it's a journey. Don't push yourself. Mindfulness and meditation and self-compassion work are not about performing for other people or looking perfect or doing it for hours. Or you can do it on the floor. You can sit. You can hang out like this. It doesn't matter how you sit, how you look, how you act. Just want you to know that. So I thank you all for those of you who came in, who stuck around, who asked questions, who sat and listened. If you need anything from me, you know where to find me. If you lose my contact info, just reach out to Leia, reach out to Pineapple. I'm always around. And for those of you that are doing XBiz Miami, I will be there to talk to you about healing through sex work. So, and of course, I'll be doing groups and talks and me and my PowerPoint. So, lots of love to y'all, and I will see you soon.